thank you very much. We're moving on to the slap lesions. Slap lesions are basically the lesions of the bicep anchor. You can see here the bicep anchor, the bicep which is attached to the supraglenoid tubercle at around 12 o'clock position. And this bicep anchor usually can be avulsed out of the supraglenoid tubercle along with the biceps-labral complex. And this biceps-labral complex will add to the stability. So this slap lesion, initially when described by Stephen Snyder, is associated with either it could be extension of the slap lesion inside the bicep tendon, or it could be associated with meniscal type of lesion, which can get incorporated, or which can come in your day-to-day activity and leading to severe pain or clinking type of sensation. Sometimes this could be associated with slipping of the bicep tendon inside the pulley, as it has been described by Gioni. And by definition, the slap lesion is the superior labrum anterior to posterior tear, which refers to the lesion of superior labrum. And this can be easily demonstrated here. As you can see in this picture, there is a superior labral lesion, but not associated with avulsion of the superior labral. Here you can see the avulsion, where there you can see the bare bone on supraglenoid tubercle. So this is a complete avulsion, type 2 avulsion of the superior labrum from the bare bone. Why you get slap lesion is because of bicep is a shunt muscle, usually associated with severe force. Whenever you're doing a throwing activity, especially in deceleration force, it can be pulled out of the supraglenoid tubercle, and this can lead to the slap lesion, as they have been described by the Stephen Burkhardt as a peel-off lesion, where you can see the bicep being involved in the throwing activity, and especially in deceleration force, it can be pulled out. Initially, when it is described as psychological or psychosomatic disorder, which can be associated with the lesion on the shoulder joint. And in many researchers thought it could be a psychosomatic disorder and not a real bicep tendon lesion. From psychosomatic disorder, it has been described as a lesion, as we have been treating these slap lesions in last 20 years after Andrews first described this slap lesion as a mean of peel back of the bicep anchor from the supraglenoid tubercle. So bicep anchor is a broad origin of the supraglenoid tubercle and the superior labrum at 12 o'clock position. This supraglenoid tubercle is 5 mm medial to the superior edge of the glenoid rim, and it reports to the origin of the bicep tendon 100% out of the supraglenoid tubercle. There are normal variation, as you can see here, the triangular labrum, bumper, meniscoid, sublabral foramina, and buffered complex. As you can see in this picture, this is triangular, this is bumper, this is buffered complex, and this is a meniscoid type of labrum, which can be seen in your clinical practice. The first classification of slap came from the Stephen Snyder as type 1, just fraying, type 2, avulsion, type 3, meniscoid type 4, extension into the bicep labrum, the bicep tendon. As you can see on this video, this is a type 1 type of bicep labral lesion. You can see only the degeneration of this initial fibers or fibrillation of the fibers. Then there is an additional classification described by Maffes, like that is type 5, type 6, and type 7, depending on the extension of the lesion into the tear. So etiology of slap could be, there are many theories. The primary theory is primary shoulder instability, traction injury, late cocking, especially in the bowlers like pitchers, or it could be a push injury, fall on outstretched hand. Internal impingement, as described by Jill Walsh, whenever you have an internal impingement, that is impingement between the rotator cuff, the supraglenoid tubercle, and the bicep labral complex. So bicep labral complex basically gets peeled off, or it gets avulsed because of this internal impingement. Clinically, it's very difficult to diagnose. One cannot diagnose a slap lesion without a proper diagnosis. There are many tests which have been described, but the clinical value of each test is not been estimated. MRI, as Anupama and Dr. Sanjay Desai were debating about how to read MRI, it's very difficult. In fact, sometimes you can have a negative slap lesion which has been reported in your MRI. Usually they may not be associated with. So MRI has not been proven as a reliable tool in diagnosing the slap lesion. So this is another slap lesion, same way. You can see is fibrillation. You can just debride it and patient will have a good pain relief because of this. So as said already, the assessing labral stability on MRI is very, very difficult. The management is very simple. You have to do an accurate diagnosis. That is very important key. And stabilization of slap lesion if required, and early return to the pre-injury status is the goal. As you can see here, this is again the same. And this is a type 2 slap lesion. Type 2 slap lesion basically is an avulsion of slap from the supraglenoid tubercle. You can see here there is a bare area here. the superior labrum has been avulsed out of the supraglenoid tubercle, and this can be easily debrided with the help of shaver. As you can see on this picture, you can just debride it. Then you create a port of Wilmington where you have to pass it anteriorly onto the supraglenoid tubercle. You won't be able to pass this through the normal anterior superior portal. You have to create an cuff port of Wilmington, and then you can pass the anchor on the supraglenoid tubercle. It can be a single load or double load depending on the choice, and you can use some hook type of devices. This is a spectrum hook device, and you can easily pass all these features so as to first fix the posterior aspect of the supraglenoid tubercle of the labrum, so the superior labrum, and then you can pass it anteriorly so as to fix your anterior part of the labrum, which is need to be fixed onto the supraglenoid tubercle. So this is how one can do a slap repair, and this is the knotless repair. Since we have a knotted, sometime you can have a knotted following slap repair because there is a direct contact of the rotator cuff onto the supraglenoid tubercle, especially the bicep labral complex, and one has to avoid that. One can use a knotless type of anchors, and these knotless anchors can be easily passed onto the anterior and posterior to the bicep labral complex so as to achieve good amount of healing onto the supralabral tubercle. So this is how one can pass the anterior and posterior anchor onto the slap lesions. So again, this is the superior labral lesion, as you can see here, and one can easily pass this. This is anterior. One can use the piercing devices. This is a simple piercing device which is going anteriorly, and again you can use the knotless type of anchor which can be placed onto the supraglenoid tubercle so as to fix this slap lesion. In rehabilitation, one has to be very careful doing rehabilitation of this patient because associated with the bicep tendon, which is the pain regenerator of the shoulder joint, and you expect absolute full recovery within 3 to 6 months. What are the current concepts? Because we have been reading it throughout the many conferences as well as many publications and papers. The current concepts of slap has completely changed. Everybody understands that bicep is a main pain regenerator, in fact pain messenger of the shoulder joint. So currently the type 2 slap region, especially associated with instability, needs to be repaired. Otherwise you should not repair the isolated type 2 slap tears. Especially in throwers who are involved in high activity or activity of throwing, you should not encourage them for a more translatory movement, and so as to consider them with the rehabilitation. So coming back to where we have left as a psychosomatic or psychological disorder, we are back to the one. Now again considering slap as no entity, no lesion, and going back to the more rehabilitative protocol rather than the operative protocol. So we have a history which is changed in last 25 years. Initially we were aggressive as regards to the slap repair. In fact, we used to repair each and every slap repair, and now where we are trying to conserve more and more slap tears so as to give more additional and stable shoulder rather than the painful shoulder. Thank you.